Good evening. This is David Little. I am private practice in San Antonio, Texas. I'm also a clinical professor at the University of Texas Health Science Center in San Antonio. And welcome tonight. I know I've been doing dentistry a long time. I teach to the freshman dental students every year. And this year when I told them that I graduated in 1984 and you can go see my picture on the wall, they went and they said, when you graduated, we weren't born yet. So I know I've been practicing a long time. I want to thank Voco, our sponsor tonight. And my office is in a little town that the Doobie Brothers made famous called China Grove. Actually, I'm outside of San Antonio. You can see my office from downtown. So my office is a little bit unique. It's built around a lake. All of my treatment rooms look at the office. I have every specialist in dentistry rotates through my practice 1 day a week. They're not part of my practice, but we can do a lot of things together and collaborate to do total patient care. This is my home team. This is my family. That's why I do everything we do. And I just had a daughter get married, so I know I'll be working for quite a while. Now, we get a lot of marketing that we don't have to pay for. If you look at every one of these that you see, what's the first thing you notice is that we all notice a bright smile. How long did it take you to look down? And it's really important in a edentulous patient that we can really bring a smile to their face. You know, it is, a lot of these patients are dental cripples, and being able to really change their life is really what it's about. And the other thing is with dentures now, a lot of new technologies are really helping us. You know, for example, there's now the ability to do digital dentures. You know, we can actually take, and instead of processing acrylic, we can mill it. And the advantage is that there's less porosity, less stain, and a happier patient. And also we can have teeth that look like teeth and really create that illusion of reality. You know, the edentulous patient is really a cripple, and with us being able to do implants and make them whole again, that's really what it's all about. We have a huge opportunity because there's so many patients that need this care, and the good news is that baby boomers are not going to put up with this. They're not going to put up with, you know, denture adhesives and those things like their parents and grandparents. They're going to seek out great care and be able to afford it. And there's a lot of patients we can help, like this patient right here. So when you see that, I want you to think about all those patients you have that have partials. Because one great service to patients with partials is that you can go in and say, you know what if I was able to place an artificial root and get rid of those clasps that you have? And also it'll keep the bone from going away and help your facial structures to be maintained. Now, I was actually in San Antonio when Noble Biocare came to the United States because they went to New York, LA, and San Antonio. And so I was involved in some of the original studies for the edentulous patient. And this slide, what I'm trying to show you here is on the left side of the slide, these are some of my very first cases. And on the right side are more recent, you know, crown and bridge cases. My point with this is that back then, you know, we would send it to the surgeon and the surgeon would say, you know, that's where I put him because that's where the bone was. But I also didn't give me any information. I want to see the end before I start. And so now the whole thing about treatment planning, especially with the edentulous patient, is we want to see the end before we start. And to do that, it takes a team approach. We all have to look at it and be on the same page, and the most important person on that team is the patient. So the first thing you want to ask that patient is, if it's an edentulous patient that's wearing a denture, you want to ask them, well, do I understand you just want something that makes it stay in better, but you still like to take it out and clean it at night? Or most of the time they say, no, if I'm going to do this, I want something that stays in. And, then you hope to have enough bone to do what you need to do. So that's the question that you ask. And here's what I ask patients. Do you want to eat what you want or eat what you can? And that's a really important thing to ask the edentulous patient, because most of these people are not eating very well. So let's talk about exam. My exam for implant patients and edentulous patients is no different than any other patient. Do a full clinical exam. What about radiology? So if I take a Panorex, how much distortion is there on a panoramic x-ray? We know that's probably between 20 and 25%. But if I take a CBCT scan, what's my distortion rate? It's 0 on hard tissue. So I can really literally measure off of this and know that I have enough bone or enough space to do the implants that we want. So let's look at a case. So if we take this, and first thing I'm going to do is take photographs and along with our x-rays and really treatment plan what we can do for the patient. And this patient, the next thing we can do is, one of the things to do is to get the CBCT scan, but the next thing is, what do you do with it? And you can use a variety of softwares to help you plan cases. And this one is a software called Dolphin that you can outsource. You don't have to own the software. I can, have this outsourced for me. But what I want you to notice on this is a really good example to show the patient how they have a knife edge ridge. And so during this, you can actually stop it and start it and show the patient exactly what you're looking at. And this is a powerful tool to be able to use to show patients, because when they look at it and say, wow, that's me, it makes it more powerful. So it's a good situation to be able to look and do that. Now let's go through and how do I treatment plan in a edentulous case, and especially if I wanted to use a surgical guide to place implants. And in this case, what I want to do is I want to build a surgical guide that is tissue-borne. So how do I pick up those soft tissue contours? Well, one thing you can do is duplicate their denture and mix it with some barium sulfate, and that will allow you now, when the patient is scanned, that you'll be able to pick up all of those soft tissue contours. And now you're able to use a soft tissue type of surgical guide. But here's the good news. You can skip this step now. All you have to do is, when you have the patient scanned, you ask for a dual scan protocol. And what that does is they'll scan the appliance. They'll take the patient's denture, put markers on it, and scan that. And then they'll scan it in the patient's mouth, and they'll get you the same picture that we're looking at here. So now that allows us to see exactly where the teeth are, and so we're able to go to the next step. So if you look at this, what this is another software, a planning software called Implant. And what this does is it allows to go through and look at exactly what implants you're going to put, what size you want to put. It has a library of every company, so you can pick out whichever you want to do. And now you can go through and look at different things. And the reason I'm showing this movie aspect is that I outsource this as well, and I get a master technician that is doing this while I'm talking to them. So I'm going to tell them, okay, I want you to measure from the mandibular nerve. I want to stay 5 millimeters away from that. I want you to put 4 implants. I want you to parallel them. And then I want to be able to see how that relates to where the teeth are coming. So all this information is gathered, and we're able to virtually plan this. And a lot of times when I'm doing these cases, I will have the surgeon, I will have the laboratory technician, maybe the company representative, and sometimes even the patient to view this, so we can show them exactly what we can do and why we're doing it and making that happen. So that software is called Implant. And once you get that information, then the next thing you do is that now you'll be able to look at the information. You can see, so in this case, I'm placing 4 implants. You can see I've got them in the confines of the neutral zone where the teeth are, which is another important feature. And this software also allows you to put in abutments. So you can look if you have enough height for that particular abutment. You can pre-plan everything before you do any of the surgery. So the reason I like doing this outsourcing is, I could manipulate this software myself, but I prefer to have a technician that knows it really well. So I can say, look, show me this lower mandible, show it to me in purple and make the nerve orange. Now the next thing I want you to do is I want you to put the teeth back on so I can see where the teeth are. And then I want you to make it translucent so now I can kind of look and see where I want the implants to go. And then I can say, okay, go ahead and put those implants in the abutments on to make sure that I have enough space for the abutment that I've chosen. So that allows me to formulate my plan virtually all the way through. And you can see as we go along, we have all the different steps to do that. And you can see, so at the end, I know that I'm going to have enough space for the abutments I've chosen. I'm able to do my planning all the way through. So in this case, I used that guide to place these implants. And knowing I had enough space, I put the abutments on. And now I'm going to pick this up in the mouth. And so we'll talk about this pickup process and how we do that in just a minute. But I want to show you just kind of how to plan the whole case. And so we can pick it up, and once that's healed, you can see how nice that looks, and we get a great, happy patient. So that's one technique. What if you don't want to go through a surgical guide and you want to just do it without a surgical guide? Here's a couple of tips. Let your surgeon, or if you're doing the surgery yourself, use their existing denture as your guide. So what this does is to make sure that I get those implants in the neutral zone. And the reason I know that and how important it is that if you get those implants outside of where they're used to wearing that denture, they'll never get used to it. And I know that because one of the first overdenture cases I did, I was all excited because it fit so well, and I told the patient, isn't that great? And he said, yeah, doc, but I just can't get used to this. It stays in, but I can't get used to it. So make sure that when you're planning, you keep these in the neutral zone. And if you don't want to grind on your denture, duplicate it, and then it gives you a platform. So if you see here, even if you're doing a full flap, that gives you that platform so that you can make sure you get those implants in the right place. The other thing is, once you put one implant, and you can see the guide pins here, you can put one right in the center, and if that's in the perfect place, use that to parallel all the way around. So that gives you that, easy way to do that. If you do want to use a soft tissue surgical guide, there are guides. This one I'm showing you here is the Expertise guide for ankylosing system. But the reason I'm showing you is this can be done where you can fixate it. You can see the fixation screws. You can also design it where you come from the facial or from the lingual, which gives you more space. So you have a lot of options with technology. Now that's a denture patient's worst nightmare, and it's a really bad nightmare if that's your patient. And one of the things we need to look at is the emotional effects of tooth loss. Most people have a really difficult time losing teeth. Especially for females, it's a real emotional thing. So if you can assure them that, you're never going to go without teeth, we can use artificial roots, we can support it, we can keep your bone there, which will keep your supporting structures. We can even immediate provisionalize, so there's a lot of advantages that we can do. And you'll also get those patients that come in and go, oh doc, I'm so happy now because, my dental problems are over. Because my mom had dentures, my grandma had dentures, now it's my turn and my dental problems are over. And, what you have to explain is, no, they're not, they're just going to be different. And here's the reason. If you look at statistically, if you and I can bite down to 150 to 250 psi, and the dentalist patient is around 50, and if they've been wearing that same denture, they're just not even chewing with that. So they really have diminished capacity, and that's why these procedures can be so helpful and so rewarding for patients. Now, I like this graph because we're going to talk about the edentulous solutions with implants. And what I like to do is to challenge all of you to come up with case fees for each of the modalities. For example, for 2 implants in an overdenture, for 4 implants in an overdenture, for a screw-retained fixed prosthesis, so that you have all of these, that it's easy for your team to present and do that. So we're going to talk tonight about, if we look at the middle one, implant overdenture, that is implant-retained, soft tissue supported. So if I tell patients, if you're functioning at about 10% with the denture you have, if you do implant-retained soft tissue supported, I can get you between 40 and 60%. 60 would be 4 implants, 40 would be 2 implants. But if we go to an implant-retained, implant-supported, or a screw-retained restoration, I can get you back functioning as good or better than you were before. So sometimes that helps to let patients see exactly what you're talking about. So let's start off with implant-retained, soft tissue supported. And the two most popular that I'm showing you here are the ball attachment or the locator attachment. You can also use ERA, O-ring, other type attachments as well. This is a great solution. And the reason I show you 4 is because 2 is a good solution as well. But I can tell you that after been doing this a long time, all those patients I put 2 implants in, they do great at first. But 5, 7 years down the road, they come in and they say, "Doc, it's just not fitting as good as it used to." So what happened? Well, where the artificial roots are, the bone stayed. What happened to the rest of the bone? It deteriorated, which means you don't have a really good fit of the prosthesis. And these prostheses have to have a soft tissue component, and it has to be a good one. It has to fit well. So they have to be maintained to keep this relationship. And so let's look at a couple of them. Here's the ball attachment, and in Texas we call that the trailer hitch. That's kind of what it looks like. It is a good attachment. It has a metal housing that can be crimped. But this is an important slide, and the reason I show you this is a lot of these patients, when they come in, they say, "Okay, I'm getting implants. I'm getting the best dentistry has to offer. I'm paying a lot of money. That should be the last thing I pay." Well, you need to explain to them up front that you are getting the best dentistry has to offer, and those implants are going to really help you. But the average person has to have a reline every 3 years, and you have to tell them there's a fee for that. And then even the best dentures that we make, the average life is about 7 to 10 years. So you have to tell them up front, you're going to have to replace this over time. Now, I tell them if you come in regularly, we maintain them, we come in for oral cancer screenings and check everything, then you're going to get a longer service out of that. So it's important, though, with all these implant restorations that you talk about the longevity in the beginning. And I call it a team approach. I'll have them come in and say, if you come in regularly, then when I have to change your little attachments, I'm probably not going to charge you. But if I don't see you for a long time, then I'm probably going to charge you when we replace those attachments. And by the way, the average attachment has to be replaced every year. So I tell patients, some people it's a year, some it's 2 years, some it's 6 months. It depends on a lot of different things. So this is an example of the ball attachment, and one advantage of the ball attachment is that it does come with a block-out sleeve that makes it easier to clean when you pick these up. And here's a patient. I love to show patients and how it really affects it. And here's a patient that she just says, "Doc, I'm in trouble. I'm really having a hard time. I just can't function, and I really need some help. Can you help me?" And so we went in and I did 2 attachments, did dentures for her, and I'm telling you, it made a huge difference in her life. And if you look at her face and look how much difference, how much better she feels about herself. And that's why we're doing this, is so we can do those type of things for patients. And that's why we do things. And I got to tell you the story. She sends me a lot of patients. I just love it. And but she came in the other day and she said, "Well, I'm kind of mad at you." And I go, "What do you mean?" She said, "Well, I sent my friend Beverly to you, and you made her one that doesn't come out." I said, "Well, guess what? We can still do that for you as well. So don't biopsy their wallet. You never know what they want." Now, this attachment, the next one we'll talk about, is the locator attachment, and it's one of the most popular on the market. One of the reasons is it's easy. Okay, are we back again? Looks like I lost people for a minute. I apologize. Okay, thank you. I was talking about the locator attachment and how it is a low-profile attachment. And that's important in a lot of situations. You just don't have a lot of space, so this is a good attachment to work with that. So if you look at the upper denture, 4 implants and a locator is a nice solution. I wouldn't cut the palate out of that with the locator because it is implant-retained, soft tissue supported. I might take a little bit away to give them a taste, but that's probably all that I would recommend there. I think the locator is a good attachment when you are doing partials, especially when you're trying to take away those big clasps that they usually have on the cuspids because it's low profile. And, you know, on the upper we can do that too. Okay, so let's talk about what we can do with what we can use to pick up these attachments, because that's an important part. And there's a lot of materials on the market, and you can see I've listed several ones that are here. So there's a lot of things that we can use, and some are resin type materials, some are you know, hard reline materials, and acrylic. So there's a lot of different choices, and let's go through a few of them. We'll show you what this looks like. The one I'm going to talk about that I use in my practice is called Quick Up, and I like it because it's a kit. It has a whole solution for picking up attachments. So let's kind of walk through, and I'll show you how this works. It has a pre-treatment, so it allows you to make sure you have space before you pick it up. Then it has a luting agent, which is self-cured. And then it has a correction, which is almost like a flowable that you can flow in to fill in the voids that you don't get in the pickup. And then that's light cured, so it makes it easy to clean off. So let's look at the locator. And one of the other things I like about the locator is they have an attachment that comes with it that gives you everything you need in that one tool. So you can see here I've got the abutment, a blockout sleeve, and then the processing ring that comes with it. So you would get those 3 pieces out. You would use the driver that comes on the tool itself to place the abutment in the mouth, and then you'd place the pickup sleeve over the top. And this is true for any attachment. All right, but here's the important parts. First thing you have to do is before you do anything, measure the vertical. Measure the patient's vertical and write that down. Put a dot on the nose and the chin, write that down. Then take and place your appliance in, relieve it, place it in, check the vertical. If the vertical is still open, then something's holding that up. But how do you know for sure how to do that? So one of the things you can do is with the Quick Up system, there is a system for that. The other thing I like about the Quick Up system, most of the time you have to cut vent holes with most of the material so that you make sure you get a good pickup. With this Quick Up material, you do not have to cut vent holes. So they have something called Fit Checker, which you syringe into your appliance, place it in the patient's mouth, have them close down, and then what happens is it'll set up quickly. And now what you can do is if you look, you can see there's little areas that are showing through. If there's an area that shows through, you need to adjust that and adjust that out until you're completely done. Now, if you don't want to use this, obviously you could use, you know, PIP paste or, you know, some other type doing it. But the most important thing, use Fit Checker and then check the vertical. That's your number one thing to make sure you have enough space. The other thing is I usually will really mark the patient's bite so I can make sure that when I have them close, I have them close in the proper position. You always want to block out with a rubber dam, or some of the systems actually have their own blockout sleeves. But whatever that is, I always make sure I block that out. And the reason is, you know, if you've ever locked one in, you won't do it again. And so I just feel better when I have a clean surface to work with that way. The other good thing about Quick Up that I like is that the adhesive is applied, and you only apply it to where you want it to stick. And the great thing about that is when you go to trim this, anything that doesn't have the adhesive is going to flick off. You can take a scalpel and just flick it off of there. So just what you want to do is make sure it's real dry, place it, make sure it's really dry again. And then now you're ready to use the pickup material. And so what you want to do is you want to fill the areas that you're picking up about 2/3 full. You don't want to overfill it. You just want to pick it up where you pick up the attachments and the retention that's in the attachment. Now here's another thing that's very important. When you seat the appliance, do not have the patient bite down firmly. You want to have the patient bite down normally and I would make sure I hold them when I do that, because typically you walk out and they'll bite really hard, and then what will happen is they'll displace one of the attachments, but you don't know it, and you'll finish picking it up, and I don't know if anybody else has been there, but you'll pick them up and then they'll pop it out with their tongue and say, yeah, it was better before I came in here. And typically the mistake is there that we have them bite down too hard. So you want to make sure you have them bite gently. The other thing you can do is use some bite registration material, so make sure you get them in the exact same position. I recommend you guide them into the position you want and hold them there while this material sets. Now, this material also sets start to finish, from mix to finish, in 3.5 minutes. So set your timer and just have the patient close into that gently and hold that position. And then once you pick it up, you're going to have some voids a little bit right around the edges of what you're picking up. So what you'll do then is take the Quick Up Light Cure material, and what that'll do is allow you to really put the material exactly where you want it, so you can just flow it around. It works like flowable, and then you just light cure it. And so now as soon as you light cure it, now you're ready to do your trimming and polishing. So that's what you would do next, is use your acrylic burrs to trim and polish, and then your polishing burrs to polish it up, and you're good to go. So the whole process really takes less than 30 minutes. So it's a very good system to use, and works really well, and patients like it as well. The next category, so what we've talked about now is a solution for those patients using 2 implants or 4 implants, which is implant-retained and soft tissue supported. And I recommend you come up with a case fee. You charge your denture fee, you charge your fee for the abutment itself and for retrofitting it, and come up with a fee that encompasses all of that. The next area we're going to move to is implant-retained, but implant supported. And the one I'm showing you here is called Syncone, and it is implant retained and implant supported. So there's a soft tissue component just for aesthetics, but you don't need the soft tissue to support the abutments. In this system, you need 4 implants on the lower and 6 implants on the upper. So let's go through this system, because it is kind of a new paradigm for overdenture systems. If you look at this diagram, it is a titanium abutment that has either 4 or 6 degree taper, and then it has a gold cap for the sleeve that holds it together. So that is how it attaches to that. Now, it can be 4 implants can be placed as long as they're parallel and stable. You can immediate load these prostheses. So it makes it a nice solution for patients to be able to do that. Obviously, there's a lot of data to back up, immediate loading in the mandible, all the way back in the late 70s. There's 4 degree and 6 degree tapers, and there's a lot of literature to back this procedure up. There's 2 key elements. One is the connection itself. There's no micro movement, so you're not going to get any movement with the tissue care connection that's there. And also that patented telescopic crown. So that gold actually work hardens over the top of that abutment, and actually these attachments get tighter over time. So it's a very good system, and we have a lot of data to back it up. The goals of it, it's immediate treatment, it decreases the treatment time, it simplifies things, and it can be very cost effective as well. So let's look at a case. And here's a patient that comes in, and obviously their normal complaint is that they had immediate dentures done several years prior. Their upper's doing pretty good, but the lower flops around and doesn't stay in. So, my treatment plan to them is that we can place 4 implants. We're going to do an immediate loaded provisional of their existing prosthesis. Then we're going to let that heal and integrate, and then come back and build them a final prosthesis. So let's walk through this and show you. So just like I showed you before, I'm going to do a CBCT. I'm going to plan it in the Simplant or the Dolphin software. Both of those work out exactly what I want to do with all the steps. And this is a very important diagnostic slide that's real important. This is not a low-profile attachment. This attachment, you need 10 millimeters minimum. 12 is better. From the head of the implant to the incisal edge of the teeth. So, for example, if you're looking at a say, an all-on-4 or a screw-retained type prosthesis. To do those immediate provisionalizations, you need 15 millimeters of space. So this is a little bit less space than that, but it still requires at least 10 millimeters. So if you don't have that kind of space, am I back again? I apologize. I don't know why that did that, but we'll keep going here. There's this implant plan. And in this case, I did a soft tissue surgical guide. So what this allows me to do is just place that on, and now that gives me the position and the angle and every detail of it. So I'm going to make it very simple for my surgical procedure. And so I went in, and now after I've placed the implants, I torque them to 15 Newton centimeters. I make sure I block everything out with that and place the gold cap. And here's an important thing. You want to make sure you have enough space, so you're going to use the techniques I showed you earlier, or you can cut a window like I did here, and this is going to allow me to visually see that I have enough space. And then you're going to do your pickup with either the quick up material or a cold cure resin or acrylic or what you're going to use. And so now you can see the patient wears that, for 1 week, soft diet. And again, you can see at the 1 week post-op there's no sore spots because it's implant retained, implant supported, so it doesn't touch the tissue. And then once it heals, then we go and make them a definitive prosthesis. So they actually end up with 2 prosthesises with this solution. Now, you don't have to immediate load, and it also, you can do this without immediate loading it, where you can actually just let it heal and then take a fixture level impression and let the laboratory line up the angled abutments. Or now we actually have the ability to let Atlantis customize these abutments for you. So the way we do this is you take a fixture level impression, the laboratory would design the abutments to the perfect degree of taper that you need. They'd make you a jig. That's what we're showing here. And now you'd go and you'd place those, using the jig, you'd place those abutments in the mouth. So once you have that, and you can see now, one of the things I recommend with these prostheses is I put a metal frame inside of the prosthesis, just not where the implants are, because I want to pick that up intraorally. I have much better success doing it intraorally on all the systems I use. And so you can see that's what that looks like. So you remove everything from that using the guide like I showed you. And now you're going to block these out. Place the gold caps on, and now again we're going to use the quick up material, and you're going to see I'm going to go in and I'm going to fill each of the areas 2/3 full. Then I'm going to seat that, and after I take that out after 3 minutes, you're going to see there's just a few voids right around the edges. And now I'm going to take and use the quick up LC material and flow that in those voids, light cure those areas, and then take and polish it and then deliver that to the patient. So again, quick and easy way to do it, patient friendly, and you can just see I've just kind of taken and polished everything up to get a good result. Another case, just going to show you, this is one where this patient comes in and says, "Doc, I'm in trouble," and I would agree, but he's only, at this time, he's only 45 years old. And so he comes in and he actually sees my associate that day, and my associate says, "We need to take your teeth out, we'll do some bone grafting, and we'll do immediate dentures." But he doesn't schedule. But I know his family, so I called and had him come back in, and I said, "I want to talk to you about, what your treatment is." And I said, "One thing is, I know your parents. How are they doing with their dentures?" And he said, "Oh, not really good. Their lower doesn't fit real well." And I said, "Well, you're going to get dentures in your 40s. They got theirs in their 60s. You're going to be way worse than they are." And he said, "Well, how do I stop that?" And I said, "Well, one way is we can place artificial roots, which will help hold the bone and maintain your facial structures, but also help hold the prosthesis." So I gave him a treatment plan that was a lot higher, and of course he still didn't have the money, but he went and borrowed the money, came in and paid up front the next day, and my associate was saying, "You're holding out on me." So all I did was tell them that, sometimes the best thing to tell them is what what would happen if you don't do anything. So in this case, we did the extractions in the lower. We loaded immediately with Syncone, and then after it healed, we made him a final prosthesis. And you can see, look at the difference that it made with this patient. You know, I tease him, it's like biker to banker. It really changed him, and just for the better all the way around. And, you know, that's why we do this. Now, my dad is a custom boot maker, and he's made boots for Absolute Vodka, and he's been on the cover of boot magazines and cigar magazines, but the best pair he ever made are these right here. I put my way through school selling boots, and my dad made me make a pair of boots, and I was terrible. The workers laughed at me, and my dad would always tell everybody, you know, my son, he really wanted to be a boot maker. He just didn't have the hands for it, so he went into dentistry instead. I just redid all my dad's dentistry, and, you know, he was like, why am I doing this? And I said, because I've got to give you the best technology I have. So he made me a new pair that shows his best technology. There's no seam. It's got some logos on it, which is my office logo, which means I can write that off. I've understood. So, all right, so now we have, you know, the first one was implant-retained, soft tissue supported, then implant-retained, implant supported, but still removable. And now the last thing we're going to go to is implant-retained, implant-supported, but screw-retained. And so let's look at a few cases that do that. You know, here's a patient that we're going to plan out to do an upper and lower screw-retained prosthesis. And one of the things that's great about now using CAD-CAM to design these CAD-CAM frames is that they have software just like we do with Simplan and other design softwares, in that we can use the laboratory technician and the tech to work together and come up with the best plan. And again, when I get on these calls and do this on a go-to-meeting setting, you know, I'm looking at the aesthetics and where the screws are coming. They're looking at, you know, how much retention am I going to have to make sure I can hold these appliances in place and do great things with it. So that gives us that benefit to be able to design everything virtually before we go to the patient's mouth, which makes it a nice solution. So if we look at here, we did 6 implants, and one of the things that I want to show you here on the bottom right is the verification jig on implants is the most important step. There is no margin for error with these being passive. They have to be passive. And the best way to check that is place your appliance in with Duralay. You can use pattern resin, you can use other things, but what you want to do is place it in, place a screw in one side, screw that screw in. If it's passive, you should be able to screw it in and nothing else should move. If anything moves, cut it, re-index it until you make sure that it's passive, because it's very important for the final fit. When I do that design online, I also have them send me screenshots so I can look at it and make sure that it's exactly what I want. Then they transfer that using the CAD-CAM and mill the bar. So they're able to mill it, and again, you can see this is built in for an acrylic teeth, which that gives them the retention to support that. And again, with these, you can design it with acrylic teeth, you can design it with porcelain, you can design it with zirconia. You have a lot of options to be able to do that. In this one, we used acrylic teeth, and so you can see this is the processing that the lab goes through to process it before they do that. And again, at delivery, you can see, because I planned it, I have access to all the screws. They're not in an aesthetic area, and so we can get a nice result to be able to do that. You know, we also can do some great things, and here's a patient that, you know, is wearing partials right now, and we're going to do upper and lower immediate loaded screw retained prosthesis. So you can see we use some angled implants here, and I always have a technician come to the office to do these cases. So when we pick them up, I let the technician do their best work. So they'll go in and retrofit these appliances, and so you can see now once it's healed, we go in and take abutment level impressions. And then again, with that, we're going to do a verification. We're going to design the case using all the things I told you before. Then we're going to try it in with wax, so we can make absolutely sure that we're getting exactly what we want before we process. Once we're happy with that, then we can process, and now we can screw retain these restorations, and you can see we get a very nice result with this as well. And again, you know, that's just another solution that you can use, and again, come up with a case fee that encompasses all of these things, and I think that's a better way to go. The latest thing out there now is we're able to make these appliances out of zirconia. You can either do full monolithic zirconia. You can also do, if you notice on this bottom right picture, you could actually make each one of these a prep and put crowns on top of them, so that you really, if something ever broke, you would able just to cut that crown off and redo that. So that's another solution. But zirconia is something that we're seeing a lot more of and for these restorations, and it's kind of the next thing that we're going to be delving in with this. The other thing that is happening now is we're able to use a lot of angled abutments, and this one I'm showing you here is called Smart Fix, and it allows you to do a two-piece for these angled abutments. So you place the first piece, then you can flip that around and now place the second piece, and that's the part that you actually end up torquing in. And one of the advantages of that is when you're working in the distal area of the mouth, you're able to get to that easier to be able to do that. So let's look at a case. We're going to do upper and lower here, but we're going to just show you the lower here, and the upper we're going to do just as a grafting and a denture first. But again, same thing. I'm going to go through and plan, and I'm going to use angled implants to avoid the nerve without having to do grafting in the posterior, just like you would do the same thing on the upper to not have to do sinus lifts. And so you can see there's my plan that we worked out in the planning software. And then here's my surgical guide that I made, and this guide is only a pilot guide. So what it does is just give me that first 2mm drill, so it gives me the position that I want it to be in. And then once I place that, now I'm able to go in, place my abutment. I'm going to parallel it with the straight ones, and then I'm able to go in and bend that out of the way, place the other second piece that goes on there. So you can see we're doing this as an immediate provisionalization. So you can see I've got 4 implants, 2 straight, 2 angled. And now I'm going to pick these up in the mouth and have my laboratory technician retrofit this. And if you'll notice, I'm showing you there's 3 options that you can use: either a screw that goes totally inside, or a screw that's flush up against the head of your Okay, I'm back. So now I let the technician fix that, and you can see there's the radiograph of the implants. And look at the difference after 3 months now. You can look at her. She's, very happy, looking good, and ready to get her final done. And here's how we do the final. So when the patient comes in, if we like the vertical, we like the position of the temporaries, we're going to take an abutment level impression. But one of the things I do is I take and use long screws, and then I'm going to take an impression to pick up the entire appliance with it. Before I take this impression, I take it off, clean it up, make sure there's space underneath it. So now when I go, I can inject my impression material underneath it. So I'm going to pick up the soft tissue, I'm going to pick up the appliance, and I'm going to pick up the position of the implants all at the same time. The laboratory will then pour up a soft tissue model. And now, since we have a bite ahead of time, we're able to mount this case right then. So while the patient sits there, we mount it. And what that does, it gives us basically a verification jig, because I picked up that in the mouth the first time. It also gives me the mounting, and now I can go directly from this point to fabricate my CAD-CAM bridge. So in this case, now I do a wax up, and now the ISIS company scans the model and the teeth, so then you can select exactly the design of your CAD-CAM. And then once you get the CAD-CAM, you process the denture teeth to that. And so you can see we get, a very nice result that is very predictable, because we can see the end before we start and plan that all the way through. And, one what we talk about with the edentulous solutions is you can go from 2 implants in an overdenture to 4 implants in an overdenture, which are implant-retained, soft tissue supported. The next level is, implant-retained, implant-supported but removable. That's the Syncone version. And then you can go to screw-retained. So that's the gamut of where we can go. And I challenge you to, come up with those solutions for your patients and have really good solutions that encompass the entire treatment, because I learned that, because it's easy for us as general dentists, if somebody says, how much is an implant, it's easy to say, oh, it's, X amount. And then you say, well, how much is a crown? And you'll say, oh, well, it depends. It depends on, well, if I'm going to use this abutment or that abutment, I got to call the lab, I got to do this. And the patients are confused. So same thing with the edentulous patient. I don't want them to be confused. I want them to say, a solution for you to take care of this is this. And I also recommend that you have, models and photographs of things that you can communicate with your patients to show them some of the choices that you can do to make that happen. So I'm going to leave the last 15 minutes here. We have about 14 minutes, and I want to go ahead and open it up for questions. And if that's okay, moderator, if you can do that for me, if you'll open that up.